Welcome everyone. Today's video is on two cases that recently came to our department in IPGMR, and the topic is Mullerian duct anomalies. So let us see the first case. This is a case of a young adolescent female girl who mainly presented with the chief complaint of dysmenorrhea. Point is that the girl is menstruating, but there is pain associated with it. With this history, let us see the images. As you can see that there is two horn of uterus. There is two horn of uterus that are widely separated from each other. And if you note that the intercornual distance is here is 8.78 centimeter. Usually in normal uterus it is less than or equal to 4 centimeter, but here it is 8.78 centimeter, implying that these are widely separated and divergent from each other. Also note that there is a separate uterine cavity. Let us see the next image. This is the pointed image for you that there is two uterine cavity and there is two uterine horn that are separated from each other widely. In the right side, as you can see that there is a well-defined cystic structure with a low homogeneous internal echo, implying that it is a hematocolpos. Whereas in left side, there cervix and the cornu was normal, whereas in the left side the cervix was normal and the vagina, but in the right side there is formation of this cystic structure with homogeneous internal echo. So if we all together put the finding, that is, we found that there is two endometrial cavity, there is two uterine horn that are widely separated and divergent in nature. Third, in the right side there is vaginal outflow obstruction resulting in hematocolpos, whereas left side is normal. If we put all these findings together, then our diagnosis is towards uterus didelphys. Now let us see the next case. Next case is an antenatal USG image. The patient was approximately 8 weeks from the last menstrual period, in 8-week gestational from the last menstrual period, and she presented with parvaginal bleeding. Upon doing the USG, we saw this image. Can you please note that there is one G-sac with a good choriodecidual reaction around it, and there is a live embryo within it. But adjacent to that there is another G-sac like structure with a little bit poor choriodecidual reaction around it, and there was no embryo within it. Also note that thin rim of myometrial tissue is present between the first and second G-sac like structure. First G-sac and second G-sac, between that there is a myometrial tissue. Why this is important? Because as there is myometrial tissue intervening between these structure, it rules out the possibility of dichorionic pregnancy. Dichorionic diamniotic pregnancy possibility has been ruled out as there is a presence of intervening myometrium between it. Upon doing a coronal scan, coronal reconstruction, 3D reconstruction, this type of images came. You can pretty well see that this is the first G-sac, this is the second G-sac like structure, and these are the endometrial cavity, and this is the outline of the uterus. So all these put together, their diagnosis was uterus bicoordinate with single live intrauterine fetus in its right horn, whereas missed abortion in left horn. Although we told it uterus bicoordinate, a close differential diagnosis will be septate uterus. Although say that 3D ultrasound is very much useful for Mullerian duct anomaly, but MRI is always a better choice. But as the woman is pregnant currently with a live fetus, that's why we avoided doing MRI here. This is the annotated image of the case. You can see this is the uterine right horn. This is the uterine right horn. This is the uterine left horn, with the fetus presented in the uterine right horn, whereas there is the missed abortion in the left horn. This is the right horn endometrial normal fetus with a yolk sac and a live embryo within it. So what is the take home message? Take home message is that these are the Mullerian anomalies. These are Mullerian anomalies. Basically, Mullerian anomalies is a broad spectrum upon which usually is 4 type of pattern comes. One is uterine agenesis or hypoplasia. Second is unicoordinate uterus. Third is didelphys. Fourth is bicoordinate. Fifth is septate. Next is arcuate, and last is T-septate uterus. Upon which didelphys is a disorder of failure of fusion, whereas septate uterus is a failure of resorption. In a simple and short gist, we can remember this like that. If the surface indentation is greater than 1 centimeter, then we'll call it as bicoordinate. If the cavity indentation is greater than 1.5 centimeter, then we'll call it as septate uterus. See, this is say 2 uterine cavity. This is the outer margin. See, this is the external surface indentation. If it is greater than 1 centimeter, then it is more favorable of bicoordinate uterus. Is the cavity indentation? Cavity indentation is this one. If the cavity indentation is greater than 1.5 centimeter, then it is septate uterus. And if the cavity indentation is between 1 to 1.5 centimeter, it is arcuate uterus. Note that arcuate uterus is a normal variant of normal uterus, normal variant, and it is pregnancy outcome is very good. Pregnancy outcome of arcuate uterus is good, whereas septate uterus has the worst outcome, and it is the most common Mullerian anomaly. Fourth point, if the horns are widely separated horn, then there is three possibilities. If there is two cervical canal, straight away go to uterus didelphys. If there is single cervix, go to bicornuate uterus. And if there is two cervix but there is bridging myometrium in between two horns, then it is bicornuate bicolis. This is rare actually. Just focus on these two things, that's uterus didelphys and bicornuate uterus. Another just important point, that diagnosis of bicornuate uterus, there are 2 or 3 points actually which we should remember. The first point is that external fundal indentation it should be greater than 1 centimeter. It should be greater than 1 centimeter. External fundal indentation means this one, that X, it should be greater than 1 centimeter in bicornuate uterus. Second is that internal indentation should be greater than 1.5 centimeter in depth. The indentation angle should be greater than 90 degree, and the intercornual distance should be greater than 4 centimeter. These 4 criteria is required for the diagnosis of bicornuate uterus. Although I skip the other Mullerian anomalies, you can see the slides of that uterine anomaly in my Facebook and Instagram page. Thank you very much.